Well, Gene, thank you very much for that kind introduction, and thank you all for the opportunity to be here this morning. It's really fantastic being able to get together with you all and talk with you about a topic that's near and dear to my heart, that being horror autoinflammaticus, the adventures in the genomics of inflammation. And of course, the term horror autoinflammaticus is sort of a takeoff on the term horror autotoxicus, which was a term that was proposed by Paul Ehrlich back at the beginning of the 20th century. He was one of the great early immunologists who recognized the severe consequences when the immune system turns against its host. And so Ehrlich coined the term horror autotoxicus, and what we're going to be talking about this morning, horror autoinflammaticus, is just basically the turning against of the innate immune system, of a part of the immune system against the host. And so we'll focus on that particular aspect of the immune system. But anyway, I hope that over the course of the next 3 or 4 hours that I have with you, that we can really get down to some details in terms of these fascinating autoinflammatory diseases. So in any event, I have nothing to disclose in terms of commercial relationships, but probably the first thing, at least for some of you, is to get down to the question of the systemic autoinflammatory diseases. What are they and why should you care? So in any case, first of all, just in terms of the definition, they are a group of disorders in which there are episodes of seemingly unprovoked inflammation in the absence of high-titer autoantibodies, antigen-specific T cells, or other features, cardinal features of the adaptive immune system, and no evidence of infection. Despite the fact that there isn't any strong evidence for the adaptive immune system being involved in these diseases, they do really manifest dramatic systemic inflammation. And I'll just illustrate this on this slide. First of all, in the left-hand side, you can see a laparoscopic view of the peritoneal cavity of a 7-year-old girl that we saw at the NIH a few years ago who has TRAPS, the TNF receptor-associated periodic syndrome. And this is one of the diseases that we will be discussing this morning. This child had episodes of intermittent sterile peritonitis, and what you can see here are basically adhesions that have formed because of the repeated episodes of sterile peritonitis. The next image is the forearm of a young man from Kansas City who has PAPA syndrome. PAPA syndrome is pyogenic arthritis with pyoderma gangrenosum and acne. And what you see here on his forearm is, in fact, pyoderma gangrenosum, basically the breakdown of the skin and the infiltration of the area with polymorphonuclear leukocytes. And this particular lesion, in the case of this patient, actually it took us a year to resolve this lesion in this patient. And then finally, the image on the right is from a patient with one of the newer autoinflammatory diseases, the more newly recognized autoinflammatory diseases. And this is a patient with DIRA, the deficiency of the IL-1 receptor antagonist, something that we published in the New England Journal about 3 years ago, and I'll be telling you about that in a little bit as well. So anyway, as I mentioned, one of the important aspects of these diseases is the fact that they are disorders of the innate immune system. And just to remind those of you who aren't thinking about immunology every day, if there is any such person in this auditorium, but in any case, the adaptive immune system, of course, is that part of the immune system where the players are lymphocytes. These are a subset of the white blood cells, and the receptors for various pathogens are receptors that rearrange in the genome and somatically mutate. Whereas the adaptive immune system is that part of the immune system that's a little bit more ancient in terms of its history in organisms. And it's the part of the immune system in which the myeloid lineage of cells plays a more important role, and in which the receptors are actually hardwired in the genome and do not somatically rearrange or mutate. Now, this slide here is just a table of at least a number of the autoinflammatory diseases. The print is probably too small for you to read, but I will just highlight the fact that there are a bunch of different classes of diseases now that have been put under this rubric of autoinflammatory. The first ones that were recognized were disorders that are hereditary periodic fever syndromes, as Jean was alluding to in the introduction, diseases like familial Mediterranean fever. But there are a host of other diseases that are also categorized as autoinflammatory, such as the idiopathic febrile syndrome, Still's disease in children, adult Still's disease in adults, various pyogenic disorders like Papa syndrome that I mentioned earlier, granulomatous diseases like Blau syndrome, and some would regard Crohn's disease as being autoinflammatory. Autoinflammatory disorders of the skin and bones, such as DIRA. We'll be talking about a few of them. And then a host of other things, such as metabolic diseases like gout, that we will talk about in a little bit. In any case, my exposure to autoinflammatory diseases and sort of the dawning of my interest in these diseases actually happened when I was a beginning fellow in rheumatology at the NIH back in 1985. I was 5 at the time, of course, and I happened to see in our new patient clinic this man, Sarkis, who was a man who was referred to us with a mystery illness. And basically, at the time that we saw him, he was in his early 20s, of Armenian ancestry, and he presented with a history of episodic attacks of monoarticular knee or ankle arthritis since infancy. These would usually occur on the order of once a month or so and would last for several days at a time. They would be accompanied by fever and an erythematous rash over the involved joint, and he would have massive effusions of his joints at the times that he would have these attacks. Between the attacks, he was totally normal, and the attacks would resolve spontaneously. So this was someone who, in his early 20s, had probably had a couple hundred of these attacks over the course of his life, but had had actually no lasting damage of his joints, and when he walked in to see us, he was between attacks and looked totally normal. And the question was, what does he have? Well, actually, at the time that I saw him, I didn't know what he had either, just as a number of other physicians who had seen him over the course of his life. But fortunately, there was a fellow in the lab that I was working in who was from Israel. And he said, Dan, it's obvious what this patient has. He has familial Mediterranean fever. And sure enough, we witnessed an attack. We aspirated some fluid from his joint, from his knee. He had like 100,000 polys per cubic millimeter in the synovial fluid, which is typical for the arthritic attacks of FMF. These patients will have an arthritis that looks like a septic arthritis, essentially. So this is something that's a cardinal feature of FMF. And at the time that we saw him, it was already recognized that colchicine is a fairly effective treatment in preventing the attacks of FMF. We put him on colchicine, and essentially he has done well ever since for the 27 or so years that it's been since we first saw him. In any case, just to illustrate some of the features of FMF, it's a recessively inherited disease. It's a disorder that is seen, as the name implies, in individuals of Mediterranean ancestry. That means Jewish, Arab, Armenian, Turkish, and Italian people. Recessive disease, attacks of fever that last on the order of usually 1 to 3 days, sometimes a little bit longer with the arthritis. They can have severe abdominal pain from steroperitonitis. They can have sharp pleuritic chest pain from pleurisy. They can have arthritis, as I described to you. They can have a skin rash as well. So these things are illustrated on this slide. This is an upright film of the abdomen of a patient having a peritoneal attack of FMF, showing the air fluid levels. My pointer isn't very strong, but you can imagine that there are air fluid levels there. A left pleural effusion in this chest radiograph on the lower left. Here in the center, you have a posterior pericardial effusion, and actually asymptomatic pericardial effusions are relatively common in patients with FMF. Up in the upper right, you can see a radiograph of the hip in a patient with chronic arthritis of the hip. Usually the arthritis of FMF is a non-deforming, non-erosive arthritis, but in about 5% of untreated patients, you can get this picture of a destructive arthritis. And then down in the lower right, you have erysipeloid erythema, which is basically a reddish raised rash, usually on the dorsum of the foot, the ankle, or the lower leg that occurs in these patients, a lot of times mistaken as being an insect bite. Now, histologically, as I mentioned, these patients have lots of pulleys in their synovial fluid or in the skin if you were to biopsy the skin. And really the thing that was the most devastating manifestation of FMF before colchicine therapy was systemic amyloidosis. Now, amyloidosis is a term that refers to the ectopic deposition of protein in a number of different tissues in the body, and there are different forms of amyloidosis, as many of you know, so that there is AA amyloidosis, AL amyloidosis, transthyretin amyloidosis, and a host of other amyloidoses in which one can have mutations in various proteins, a lot of them that are serum proteins. In the amyloidosis of FMF, what is being deposited is serum amyloid A, which is an acute phase reactant which is produced by the liver during the inflammatory attacks of FMF. And a cleavage product of SAA is what deposits in the kidneys and several other vital organs. And before the advent of colchicine therapy in FMF, amyloidosis was actually a major cause of death in FMF patients. Now, back in the mid-1980s, this was a fascinating disease. It was a disease we didn't know what caused it. It was a disease with dramatic inflammation, and this was really at the advent, at the dawning of the Human Genome Project. And so at that time, it was just becoming possible to map genes that cause human diseases by basically comparing the inheritance of those diseases in families with the inheritance of DNA markers, which were just being discovered at that time of known chromosomal location. And so I thought that if others could be mapping and cloning the gene for diseases like cystic fibrosis, why couldn't Dan Kastner find the gene that causes FMF? And of course, the naivete of youth is a good thing. When you're 5 years old, you know, these kinds of things are great. And so, fast forward a little bit, this is a HIPAA-approved photograph of a family that I visited in Israel. So basically, in the summer of 1989, I spent the summer with this guy here, Dr. Mordecai Pras, who ran a very large FMF clinic in Tel Aviv. And he made available to me patients with FMF as well as unaffected family members. So in some cases, they couldn't make it to the clinic, so we went to them. And you can see after getting informed consent, there's a notebook with the informed consent documents, everyone would roll up their sleeves and give blood. We would have lunch. It was a great thing. And here, this happens to be a family from Akko, which is a northern coastal town in Israel. They are of Moroccan Jewish ancestry and actually a consanguineous family. The parents in the family were first cousins to one another, and you may note the strong intrafamilial resemblance between mom and dad in this family. And then also pictured here are several members of the family affected with FMF, as well as one of the members of the family up here in the upper left, our upper left, who's totally unaffected and turned out later, once we had the gene, not even to be a carrier for FMF. So in any case, we did do what we set out to do, which was to map the gene for FMF, and it turned out to be on the short arm of chromosome 16. And then we became sort of the genome project for that area of the human genome. This was back at the time when things were just really getting underway in terms of the genome project. And so we developed fairly high resolution maps of this region of chromosome, oh, that's where it is, in the middle, high-resolution maps of this area of chromosome 16, narrowed things down to about a 200 kb interval. There were 10 genes that we had to figure out were encoded in that region, and of course, as our luck would have it, it was the 10th of the 10 genes that we looked at that had mutations in it that were, in fact, associated with inheritance of FMF. So in any event, we did find then a gene depicted here, MEFV, mutations in which cause FMF, and it encodes what was then a predicted protein shown here, which we called pyrin after pyrexia. Now, at the time that we were actually at the point of finding the gene, we were in a fight to the death with a French group. A race to the finish line. And so this was actually in July of 1997, so 15 years ago. And so, and we and they found the same gene. Fortunately, it was the same gene at the same time. And we named the encoded protein pyrin after pyrexia for fever. The French group, being much more erudite than we, called it marinostrin after Mare Nostrum, for the Mediterranean Sea. That was the Latin for the Mediterranean Sea. We chose a name that would be relatively short, easy to pronounce, and perhaps easy to remember, hoping that then we didn't know for sure that the French had something, but we figured if they did, it would be good, at least in terms of what name would finally stick, that our name would be one that would be easier to remember. So anyway, we called it pyrin after pyrexia. And at the time, it was a novel protein. It was a protein that hadn't been recognized before. And it turns out that the N-terminal 90 or so amino acids, at that time, again, it was not known, but that domain turns out to be a domain that's found in some 20 different proteins in humans that are involved in the regulation of inflammation and apoptosis. And so this actually became something that was more or less a key to understanding a whole branch of regulation of the innate immune system. And that domain, I will tell you, everyone refers to as the pyrin domain. Not the Mare Nostrum domain, but the pyrin domain. So the pyrin domain, it turns out, forms this 6-alpha helical structure shown here in the upper left. And that structure is sometimes referred to as a death fold, because it's seen in death domains, death effector domains, caspase recruitment domains, and pyrin domains. Now, pyrin domains are actually the most numerous of these 4 families of domains. The interesting thing about this structure is that it allows the formation of a dipole, with positive charges being shown in blue here and negative charges being shown in red. And the idea is that by forming this dipole, what happens is that you can get then cognate interactions, self-self interactions between pyrin domains. And so pyrin domains of one protein can interact with pyrin domains of another protein, basically to allow for intermolecular interactions and for various regulatory processes to happen in the cell. So the pyrin domain of pyrin interacts with a protein that is sometimes known as ASC, apoptosis-associated speck-like protein with a card domain, which is why most people call it ASC. And ASC is a fairly small protein. It has a pyrin domain at its N-terminus and a card domain, which is also a domain in the same death fold configuration. At its C-terminus, the card domain of ASC interacts with the card domain of caspase 1. And caspase 1, some of you may know, is actually the enzyme that catalyzes the conversion of pro-interleukin-1 beta to interleukin-1 beta. And interleukin-1 beta, IL-1, is one of the major mediators of fever and inflammation in humans. And so this basically ties pyrin to the regulation of this process of IL-1 activation. We have generated mice over the course of the years that harbor mutations in them in the mouse pyrin that are the same mutations as what we see in humans with FMF. And you can see on the left, here's a wild-type mouse, and then a litter mate that has the V726A mutation. That's one of the FMF-associated mutations, substitution of alanine for valine at position 726. And you may see here that, in fact, this mouse has arthritis of its hind paw. And if you section the joint, there's lots of polymorphonucleoleucocytes in the synovial fluid. Moreover, if you compare the peripheral blood leukocytes in the V726A bred onto a wild-type background, there's a granulocytosis in these mice. But if you breed it onto an IL-1 receptor knockout so that you're blocking IL-1 signaling in the mouse, that goes away. Now, you may say, well, we don't treat mice, so what? So I'll tell you, so what? So in any case, back in, I think it was 2005 or something like that, we had this patient who was sent to us from the Mayo Clinic, who was a man from Baghdad, Iraq. He was 18 years old at the time. He's homozygous for the M694V mutation at the FMF locus. Now that's the most severe. That's the mother of all mutations at the FMF locus. And patients that have that mutation, if they're not treated aggressively, can develop amyloidosis. And so at the age of 18, he actually did have systemic amyloidosis. He had amyloid in his kidneys and had a creatinine at the time that he came to us of 3.5. He had amyloid in his heart, which is actually relatively unusual for AA amyloid, but he had it, and he had an ejection fraction of 37%. He had amyloid in his gastrointestinal tract, which led him to have malabsorption and chronic diarrhea. And this is just all illustrated on the images here. So this is the glomerulus of the kidney, and you can see when it's stained with Congo red. Looked at under regular light, it looks like this. Under polarizing light, you can see the apple green birefringence that's typical for amyloidosis. Stained with anti-AA, monoclonal antibody, it shows up this way. Here's amyloid in his duodenum, causing chronic diarrhea, malabsorption. Here's amyloid in his heart. This is an anti-AA stain. So anyway, given the fact that he had amyloid in his GI tract, that he had chronic diarrhea, and that actually what happened was that I went to give a talk up in Connecticut at a Gordon conference, and I got this message at the end of the talk that I should call the ICU at the NIH as soon as possible. So I called the ICU. This guy had, while I was away, gone into renal failure and heart failure and was in the ICU. And there was the question even as to whether we should support him because of the fact that he had already such advanced amyloidosis, and what were we going to do for him, and could we do anything like a kidney transplant for such a patient as this, because this is a process that seemed irreversible. But at that time, there was just beginning to be the thought that amyloid is actually a dynamic process in which you have deposition of whatever is the protein that's being deposited as the form of amyloid, but there's also a resorptive process. And that if you could block the deposition of amyloid, that the resorptive process would eventually lead to improvement in the patient. Well, we couldn't treat him aggressively with colchicine because he had diarrhea, and as many of you know, colchicine causes diarrhea. So what to do? Well, we were just beginning to see the light with regard to the connection of pyrin with IL-1. So we thought, well, maybe we should treat him with an IL-1 inhibitor, which we did. And here, this is just on the y-axis, acute phase reactants, either the serum amyloid A or the CRP, while he was on, at least in this image, while he was on anakinra, which is the IL-1 receptor antagonist, you can see that, in fact, his acute phase reactants were well controlled. We had to stop it for a period of time because he was septic. But in any case, we continued the treatment with him, and actually his amyloid has not totally gone away, but certainly much improved, so that at this point his ejection fraction is 55%. He's able to eat pizza for lunch. He's had a kidney transplant, and here's a picture of him, a recent picture of him. So in fact, this has been, for some patients, a life-saving kind of thing. And there's actually an article that's going to be coming out in the Annals of Internal Medicine, a study that we were involved in at the clinical center using a different IL-1 inhibitor, rilonacept, in a randomized placebo-controlled trial showing that rilonacept is effective in the treatment of FMF. That's another IL-1 inhibitor. All right, so in any case, let's move on to another disease. I think you've heard enough FMF for the morning. So let's talk about another patient, Christina. Now, Christina is a patient that was referred to us at the NIH while we were looking for the gene for FMF. And she was not of Mediterranean ancestry. Instead, she was Irish. She was actually referred, her husband worked at the Irish embassy. There was an Irish anesthesiologist at the NIH who called me up one day and said, I hear you're working on familial Mediterranean fever. I said, yes, that's true. Well, I've got something for you. I've got a patient with familial Hibernian fever, Irish fever. So I said, all right. So anyway, she came to the NIH. We saw her, 27 years old. At the time, she had a 14-year history, going back to age 13, I guess, of 3 to 5 week febrile episodes. Now remember, I told you that the episodes of FMF last on the order of 1 to 3 days. So this is way too long for attacks of FMF. She had abdominal pain with her attacks, which of course you can have with FMF, but she had a couple of other things that usually you don't see with FMF, periorbital edema and a migratory rash. We saw her about 1 week after she had delivered a healthy baby boy, and she was just going into an attack. During her pregnancy, she was totally attack-free, and this is actually quite typical for the disease that I'm going to be telling you about. She had high white count, elevated acute phase reactants, and had a history of responding to corticosteroids, but not colchicine. So she was not of Mediterranean ancestry. She had these prolonged attacks. The attacks had manifestations that aren't manifestations that you usually see in FMF. And she responds to steroids, but not colchicine. And here she is in the pedigree, and you can see that this looks more like a dominant pattern of inheritance. She's got 3 sisters who are affected, her mother's affected, well, the maternal aunt isn't, but then there's a maternal cousin who is. So what is this? And this actually had been called in the literature. There were a couple of cases reported, a family reported. It had been called familial Hibernian fever because it had been described amongst the Irish. And there even had been the hypothesis that perhaps the Irish are actually descended from Jewish sailors who were part of the Spanish Armada, which was shipwrecked, and that they swam ashore in Ireland and actually intermarried with the Irish population and introduced a dominant form of FMF into the Irish population. This was the thinking that was going on at that time. Well, in any case, so we had this patient, and for a while we just took care of her and didn't know what it was, and we didn't have the gene for FMF at the time. Once we found the gene for FMF, then we screened that gene for mutations to see if there was some different kind of mutation that would cause a dominantly inherited form of periodic fever. Nothing there. In the meantime, my former fellow, Mike McDermott, a good Irishman, actually finished his fellowship at the NIH, took a job over in London, and tracked down the original Hibernian fever family and mapped the gene in that family to the short arm of chromosome 12. And in the meantime, we had accrued several other families with dominantly inherited fever. And so it did appear that there was this region on chromosome 12, short arm of chromosome 12. And of course, the FMF gene is on chromosome 16, so it can't be that gene. Some gene on chromosome 12 that might be causing this. Now, the region that Mike had mapped the gene to was much too large for us to just look at a few candidates. And actually, Mike came back to my lab to do a sabbatical to try to figure out what the gene was. So at first, while we were trying to find more families to narrow down the region, we subjected this interval of the genome to a very important test, the embarrassment test. So the embarrassment test is, you look at all the genes that are known in a given candidate region. You think about the phenotype. and you think, well, what gene would it be that would be the most embarrassing, that if we spent 5 years looking for it, and then we found it by some positional approach or whatever, and then people would say, well, we could have told you that at the beginning. So the gene in that interval that seemed to be, would be the most embarrassing if it turned out to be it, was this one here, TNFR-SF1A. And it's the gene that encodes the 55 kilodalton receptor for tumor necrosis factor. Now, tumor necrosis factor is another mediator of fever and inflammation in humans. There are 3 major mediators of fever in humans: IL-1, TNF, and IL-6. So this is TNF, the TNF receptor. There's actually 2 TNF receptors in humans, a 55 kilodalton TNF receptor that's encoded here, and a 75 kilodalton receptor that's encoded on chromosome 1. The protein that's encoded by this receptor is shown here. It has 4 cysteine-rich domains, a transmembrane domain, and intracellularly a death domain. So it's actually a cousin of pyrin, because remember, death domains and pyrin domains are similar in structure. So in any case, Mike McDermott and Ivona Aksentievich, one of the people in my lab, set out then to screen this gene for mutations. They started actually in October of 1998. And on Thanksgiving Day, I have a very hard-working group in my lab. They came in to check their electropherograms of their sequences, and they found on Thanksgiving Day, mutations in 7 different families with dominantly inherited fever in this gene. That was the discovery of this disease on Thanksgiving Day. 1998, we had Thanksgiving dinner as a lab afterwards at Ivona's house, actually. So anyway, the mutations that they found are mutations that disrupt this loop-de-loop structure. See, there's a fancy folding structure of these cysteine-rich domains that basically involves the formation of disulfide bonds. And the disulfide bonds essentially form between cysteines. And if you have a mutation that substitutes something else for a cysteine, the disulfide bond can't form. And if the disulfide bond can't form, it doesn't fold right. So this thing doesn't fold right because you have mutations that substitute something else for the cysteines, such as, for example, C52F here, where you have a phenylalanine instead of a cysteine at position 52. So in any case, that then leads to this disease. Now, in the original, now this is just sweet irony, in the original Hibernian fever family, it was actually a family of mixed ancestry. One side of the family was Irish, the other side of the family was Scottish. They were being seen at a center in Nottingham, England, and I guess that the group in Nottingham figured that the fever must come from the hot-blooded Irish side of the family. But in point of fact, when we knew what the gene was and what the mutation was, turns out it came from the Scottish side of the family. So it should have been Caledonian fever, not Hibernian fever, but actually at that time with the 7 families that we had like a Finnish family. So should it be, Finnish fever or something like that? Well, we decided probably best, just as a matter of international diplomacy, to take the ethnic attribution out of the name. And so we came up, again, thinking of short names that would be easy to remember and that people would quote. We came up with the name TRAPS, TNF receptor-associated periodic syndrome. And so that's what this disease is called nowadays. And here are just some clinical images of patients with TRAPS. I already showed you this one. This is the adhesions in the 7-year-old girl with repeated episodes of peritoneal inflammation. This is pleural thickening in a middle-aged man with recurrent episodes of pleurisy. This is the migratory rash of TRAPS, which is quite interesting. It's a rash that starts proximal and moves distally, oftentimes on an extremity. In this case, this man has the rash on his inner thigh on this particular day that the picture was taken. And then it might be on the knee the next day, the calf the next day, the foot the next day. So it moves down. It's not spreading, it's moving. And if you look by magnetic resonance imaging, you can see that the inflammation actually goes down into the muscle compartment. It's not a myositis, though. It's a fasciitis that these patients have. You can see there's conjunctivitis these patients can have. They can have periorbital edema, and they can develop amyloidosis. This is a kidney biopsy stained with an anti-AA monoclonal antibody. So in any case, what causes this? We had thought at first that the mutations led, and they do, lead to a problem of shedding of TNF receptors off the cell surface. Retention of the TNF receptors would then lead to repeated signaling through the receptors. That does happen, but it appears to have a rather minor effect in terms of the inflammation. What actually is the problem in TRAPS is constipated monocytes. So in any case, what happens is that when these receptors misfold, there's a problem with the trafficking of the receptors from the endoplasmic reticulum to the Golgi apparatus and then to the cell surface. So that if you compare what happens with wild-type receptors in this transfection system, you can see that you get the green is the receptor, the red is just a marker for the Golgi, and you can see that there is co-localization of the wild type with the Golgi apparatus. But in the case of the mutant receptor, you can see that it just gets stuck in the endoplasmic reticulum. And you can see actually in cells from patients, these are human patients with TRAPS, and you can see that there's a retention of TNF receptor intracellularly compared with wild type. What that does is shown here on this slide. So when you signal through the TNF receptor, when TNF signals through the TNF receptor, what happens is TNF is actually a trimer in the bloodstream. The trimer of TNF binds to 3 of the TNF receptors. It induces trimerization of the receptors. And when that happens, it brings together in close apposition 3 of these death domains on the intracellular side of the cell membrane. And that then engages a signaling complex that leads to cytokine activation in the cell. When you have these mutant receptors, they actually aggregate in the endoplasmic reticulum. And so there is actually then constitutive aggregation of these death domains intracellularly, which leads to constitutive activation of the pathways that lead to inflammation through the TNF receptor. So that's at least the major mechanism of inflammation. Let's now turn from FMF, from TRAPS, to 3 other diseases. This is a threefer. That are caused by mutations in the same gene. And this is one that's really near and dear to my heart because, in fact, it turns out that this gene encodes a protein that's a cousin of pyrin. So anyway, so these 3 diseases are sometimes known as CAPS, cryopyrin-associated periodic syndromes. So the common feature in these diseases is that these patients have fever, recurrent fever, with a hives-like skin rash. It's not true hives. They don't have mast cells in these lesions. They don't have elevated levels of histamine in their bloodstream. It's neutrophils, actually, that are in these skin lesions. And there are 3 diseases. One of them is called FCAS, familial cold autoinflammatory syndrome, or urticaria. It's cold-induced hives and fever that these patients will get. It's dominantly inherited. The person, if they go out in the cold for an hour or so, they'll break out in hives and have a fever. If they walk into an air-conditioned room, if they live in the South, and a lot of these people have moved to the South because of avoidance of cold weather, basically. If they go into an air-conditioned room, they'll break out in hives after an hour or so. And they feel lousy, and they have to actually go to bed in order to recover. The second disease that's also caused by mutations in the same gene is a disease called Muckle-Wells syndrome. It's not cold-induced, but the patients get fever. They get the same hives-like rash. Actually, this patient here has Muckle-Wells. They have arthritis. They can develop sensory neural hearing loss, and they can develop amyloidosis. And then the most severe is a disease called NOMID, neonatal onset multisystem inflammatory disease. In Europe, it's called SINCA syndrome, chronic infantile neurologic cutaneous and articular syndrome. And that is a disease in which there's fever, hives-like rash, bony overgrowth of the epiphyses of the long bones, and most devastating, CNS disease. These patients develop basically a chronic aseptic meningitis that leads to blindness and deafness and mental disability. So it's a very severe illness, and actually wasn't thought to be genetic at first because most of the patients who develop it have it as a spontaneous, a de novo mutation and never have children of their own. So it was thought to be a sporadic disease a few years ago. So in any case, Hal Hoffman at the University of California, San Diego, looking at some families with cold urticaria and Muckle-Wells, mapped the causative gene to the long arm of chromosome 1. And in the candidate interval, this was around 2000, 2001, he found a predicted gene that had a pyrin domain. So he applied the time-honored embarrassment test to this region and decided that he would screen the gene for mutations associated with these two diseases. And lo and behold, he found that there were mutations in this gene in the so-called Nacht domain, which is just an acronym. It has nothing to do with falling asleep at night or anything like that. But in any case, this protein has a pyrin domain at its N-terminus. It has a Nacht domain, which is a protein interaction domain in the middle, and a leucine-rich repeat domain at its C-terminus. It can interact with ASC, that same protein that pyrin can interact with, and it also can have a role in activating IL-1. Now, at the time that Hal was doing these studies, we were seeing a patient with Muckle-Wells, and my colleague, Rafaela Goldbach-Mansky, was seeing this young man from North Carolina named Jonathan. And Jonathan had been sent to the NIH with possible Still's disease, systemic onset JIA. And here's his picture back 10 years ago or something like that. And here he is. I don't know that you can make the diagnosis of systemic onset JIA from this picture. But there were some other features that didn't seem typical for systemic onset JIA. He had a hives-like rash. He had papilledema. He had some element of ventriculomegaly, and he had these knobby-looking knees, which are pathognomonic for NOMID. This appearance of the knees is what NOMID knees look like, or SINCA if you're in Europe. So Rafaela correctly diagnosed this patient as having NOMID, neonatal onset multisystem inflammatory disease. And it was the two fellows who were on service that actually catalyzed this discovery. So these fellows had been seeing my patient with Muckle-Wells and had been seeing Rafaela's patient with NOMID. And they said, well, the skin rash of these two diseases looks very similar. Are you sure that they're not the same disease? We said, no, they're not the same disease. What haven't you been reading? But they insisted. And so we thought, well, maybe they're right. Maybe there is some connection there. And of course, the gene for Muckle-Wells had just been identified by Hal Hoffman, so we knew what that was. So we decided, well, we'd check it and see whether or not Jonathan, this patient with NOMID, in fact, had mutations in this gene, the gene that encodes this protein cryopyrin. And so here's Rafaela, the person that saw Jonathan, and Ivona, who did the sequencing. And lo and behold, what they found was that, in fact, there was a mutation in cryopyrin in NOMID. And then, this is one of these great NIH stories. So, we were telling people about this, wasn't it interesting? And it happened that there was this guy, Sergio, from Argentina, who was a fellow up on the 11th floor, 2 floors up from us, who had brought a couple of DNA samples with him from Argentina of NOMID patients in the hopes that there would be someone at the NIH doing studies of the genetics of NOMID that he could then collaborate with. So he gave us these samples after appropriate paperwork was done, and sure enough, they had mutations in this gene too. And it turns out that about half of the patients with NOMID have mutations in this gene. The mutations are clustered in the Nacht domain, just as they are for the other two diseases. And in fact, the balls, the different colored balls, represent mutations associated with the different diseases. And you can see they're all clustered in the same region. We have no idea why one mutation causes one of these diseases and another mutation, the other disease. The pyrin domain is almost invariant. The leucine-rich repeat domain seldom has mutations either. And so this, the gene encodes this protein cryopyrin. Pyrin, because it has a pyrin domain, cryo, because at least some of the patients have cold-induced symptoms. And cryopyrin forms a macromolecular complex, and this is actually something that if you're taking boards or whatever, you probably ought to know. The macromolecular complex is called the inflammasome. And the inflammasome, you don't need to know all the components of the inflammasome, but it is basically a complex that's involved in the activation of IL-1 beta. It's one of several complexes that can activate IL-1 beta. So you have this inflammasome, and basically the mutations that are associated with these diseases are in the NOX domain, and they're activating mutations that turn on this process all the time, constitutively. So we reasoned that if IL-1 is turned on all the time in these patients, just like I told you about the patient from Baghdad, Iraq, that we decided to treat with anakinra, we decided that we would do a trial of anakinra in NOMID, because this is a devastating disease. And we thought that if there was something that really deserved some attention, it was this disease. On the left-hand side of the image here, you can see how IL-1 ordinarily signals. You can think of IL-1 as blue bubbles, just for purposes of this discussion. And IL-1 has to bind to two chains of its receptor in order to signal. The green type 1 IL-1 receptor and the purple IL-1 receptor accessory protein. It has to engage both of those receptors in order to deliver a signal. In all of us, we have something called IL-1 receptor antagonist, which is basically a protein that can bind to the type 1 receptor but doesn't bind to the accessory protein. So it competes with IL-1 to bind to its receptor, and basically it can bind but it doesn't signal. So it's basically a way of turning off signaling by IL-1, and it's something that normally happens during inflammation in people, is that you get IL-1 receptor antagonist levels going up in the bloodstream, at least in part as a homeostatic mechanism to tone down the inflammation. There's a recombinant form of this that's known as anakinra, or Kineret, the trade name. And so anyway, we did a trial of anakinra in NOMID. And essentially the results are shown here. It was published in the New England Journal in 2006. Within 2 or 3 days, the hives like skin rash goes away completely. The conjunctivitis goes away completely. Within 3 months, this white here, this is the chronic aseptic meningitis. This is an MRI with a FLAIR image, and basically all of the white is inflammation, and you can see it's gone basically within 3 months. The arrow points to the cochlea. This is a Fiesta image of the head, and this is cochleitis. This is what leads to deafness in these patients, and the cochlear inflammation goes away as well. So anyway, this has been a very effective treatment for NOMID. So now we have a little quiz here. And we'll go a little bit more quickly through the other diseases, because we have several other diseases to talk about and only 14 minutes to do it in. So anyway, here's your quiz. So could this be NOMID? So here is a patient, a 9-month-old child from Canada, who was referred to us with this total body pustular rash. And here's the hair, so this is the fold of the neck. It's pustules all over the body. The patient had a multifocal osteomyelitis, aseptic osteomyelitis. And you can see here some of the punched out lesions the arrows are pointing to throughout the body. And then the patient also had evidence of vasculitis. So from what I told you about NOMID, is this NOMID? No, of course not, because the skin lesions of NOMID are hives-like, not pustules, because the bone lesions of NOMID are overgrowth of the epiphyses of the long bones, the knobby-looking knees, not multifocal recurrent osteomyelitis. And I didn't say anything about vasculitis in NOMID. So this was not NOMID. We were asked, is this NOMID? Just given the pictures, we said, no, it's not. We actually did sequence for mutations in cryopyrin, didn't find any. But the referring physician from Canada was an obstinate character, and so he treated the patient with anakinra anyway. And this is what happened. So here's the child before treatment, and you can see pustules on the face. Within 3 days, this child is starting to shed his skin. You can see he's kind of smiling here. And within a week, he'd shed nearly all of his skin. Pustules went away completely, and the multifocal osteomyelitis resolved within 2 or 3 months. So what is this? What could this be that basically responds to an IL-1 receptor antagonist, but it's not NOMID? Well, again, this important test, the embarrassment test, once again, comes to the rescue. So we were thinking, well, okay, so here's a patient who responds to the IL-1 receptor antagonist. So what gene would be the most embarrassing that if it turned out to be it, and we hadn't looked at it first, which one should we look at first? Well, of course, it's the gene that encodes the endogenous IL-1 receptor antagonist. So we looked at that, and lo and behold, what we found was that this patient was homozygous for a 2 base pair deletion in the coding region of the IL-1 receptor antagonist gene. That's almost too good to be true. Homozygous for the same 2 base pair deletion? How could that be? You know, so we sequenced the parents. Sure enough, the parents were carriers for it. The kid really is homozygous for the 2 base pair deletion. And then, of course, we took a better history, and it all became clear when we learned that the patient was from Newfoundland. And so basically the explanation there, of course, is that Newfoundland is an island off the eastern coast of Canada, and many of the current residents of Newfoundland are descendants of settlers who came to Newfoundland actually 200 years ago. And they are at least, you know, distantly related to one another in the sense that there's a founder population there. And so probably one of the early settlers to Newfoundland had this mutation, just as a heterozygous would have no symptoms associated with it, but it just happened that the 2 parents both were carriers for this, and then the child was as well. We now know that there are other mutations in this gene, for example, a stop codon amongst people living in the Bible Belt of the Netherlands. There's another mutation that we see in the Middle East, yet another mutation in northeastern Puerto Rico that are associated with this phenotype. And so we, again, thought that because there are mutations in the same gene associated with a particular phenotype, we would give this disease a name, and the name that we have given it is DIRA, the deficiency of the IL-1 receptor antagonist. Again, adhering to the naming conformity of short, easy to pronounce, and easy to remember. So in any case, this table just summarizes the comparison of NOMID with DIRA. Different genes are involved. The functional consequences for NOMID, it's activation of the inflammasome. For DIRA, it's decreased inhibition of IL-1. Different skin rashes, different bone manifestations, different CNS involvement as well. And then finally, the last of these monogenic diseases, and maybe we'll curtail things a little bit so as not to get into the lunch hour, but in any case, this disorder that we'll talk about just briefly is PAPA syndrome. So here is very severe cystic acne on the back of one of our patients with PAPA syndrome. And it's caused by mutations in this gene, PSTPIP1, which actually encodes a protein that's a pyrin-binding protein. And so it just goes to show how mutations in all different aspects of this pathway of regulation of IL-1 can actually lead to different inflammatory diseases. So in this case, actually PSTPIP1 binds to pyrin, and in fact, the disease-associated mutations are associated with increased binding of PSTPIP1 to pyrin, which leads to increased IL-1 production and other cytokine production. So this schematic is just a depiction of IL-1 activation, some of the steps in IL-1 activation. And what I've shown you is that depending on where in the pathway you're looking, if you're mutating pyrin, you can have this erysipeloid erythema skin rash. If you're mutating PSTPIP1, you can get pyoderma gangrenosum. If you're mutating NLRP3, you get these urticaria-like skin rashes. If you're mutating the IL-1 receptor antagonist, you get this total body hives-like rash. So in any case, there's a number of different diseases that are all caused by mutations in this pathway. And in fact, DIRA is the prototype for a group of diseases in which receptor antagonists are mutated, and just one that was published in the New England Journal a year or so ago is a disease now called DITRA, deficiency of the IL-36 receptor antagonist. And basically IL-36 signals in a similar way to IL-1 with a binding of 2 chains of a receptor and a receptor antagonist that only binds to 1 chain. And those patients get a form of pustular psoriasis. Now maybe I'll just finish up by indicating to you that in fact these pathways that I've told you about, that we've learned about through these monogenic diseases, are pathways that are important in some much more common genetically complex diseases, so that we now know that monosodium urate, for example, activates the inflammasome, and that at least some of the inflammation in gout is due to excessive IL-1 production, and in fact, there have been successful studies of IL-1 inhibitors in gout. Type 2 diabetes, actually, is another disorder, genetically complex, that has an IL-1 component to it. It turns out that islet cells of the pancreas synthesize IL-1 beta, induced by hyperglycemia. IL-1 beta is actually toxic to islet cells. So hyperglycemia causes islet cells to make IL-1, which causes them basically to commit suicide, which then leads to further hyperglycemia. So that actually, if you treat patients with type 2 diabetes with an IL-1 inhibitor, as shown in this paper in the New England Journal from a while ago, glycemic control is actually improved. And then probably the most common of these diseases, atherosclerosis. So atherosclerosis has, as I think many of you recognize, an inflammatory component. And if one looks at mouse models of atherosclerosis, here's cholesterol deposition in a wild-type mouse. But if one knocks out various components of the inflammasome, NLRP3, which is cryopyrin, ASC, or IL-1 knockouts, these mice do not develop atherosclerosis. Now, you may say, well, that's great for the mice. But in fact, there is a trial, the CANTOS trial, that is going on right now. It's a trial that Novartis, the maker of a monoclonal antibody against IL-1, canakinumab or Ilaris, and this is a trial of 17,200 patients who have had myocardial infarction, treating them either with placebo or with 3 different doses of this anti-IL-1 antibody. And the outcome, what they're looking for as the primary outcome, is the number of second cardiac events effectively in these patients, with the idea that blocking IL-1 will prevent recurrent cardiac events. Just the drug for each patient that's getting active drug is about $100,000 a year, so that for 17,200 patients, you're talking about a trial that's $1 billion trial. So definitely these pathways are important, or thought to be important. We believe they're important in common diseases. Well, we don't have time to talk about CANDLE, which is another interesting new disease that we're working on, or about PLAD. This is another disease we published in the New England Journal earlier this year. We'll just flip through these slides. Or about a disease that's coming out next month in the American Journal, or about Behçet's disease either. But you see, these are all things that maybe would get you to invite me back some other time for another talk for part 2 of this. So I'll just, go through these slides, some very interesting associations along Marco Polo's Silk Route, but you'll have to hear the next installment to know about that. And here's just maybe to finish up a pie diagram of some almost 1,900 patients that we have studied genetically at the NIH in our autoinflammatory diseases clinic. And the interesting thing is that only in about 1/3 of them do we have a genetic explanation. In 2/3 of them, we don't. Now, not all of them probably have a Mendelian disease, but this just highlights the point that there's plenty more to be found amongst these patients, and that there's, I think, still a rich source of patients for study, and that we can learn a lot from these patients. So just to summarize, the autoinflammatory diseases manifest constitutive or easily triggered innate immune activation. Mendelian autoinflammatory diseases have provided important insights into the regulation of inflammation. IL-1 beta activation, protein misfolding, and, well, we didn't talk about proteasome dysfunction, but take my word for it, are 3 mechanisms of Mendelian autoinflammatory disease, based on the demonstration of an important role for the inflammasome in their pathophysiology. A number of common disorders, such as gout, type 2 diabetes, and atherosclerosis, have been shown to have an autoinflammatory component. And again, for the next talk, genome-wide association and next-gen sequencing studies allow the identification of susceptibility loci for more common but genetically complex autoinflammatory disorders. Here's just the cast of characters that really made all this happen, and of course the clinical center of the NIH where we carried out most of these studies. So anyway, it is now 1 minute to 9. I apologize for talking a little bit over, but hopefully you've learned at least a little bit. Thanks a lot. Yeah, those are both great questions. So we do believe that the more effective treatments for inflammatory disease have led to a reduced frequency of amyloidosis. Certainly, chronic infectious diseases, things like tuberculosis, were common causes of amyloidosis back in the age before there were effective treatments for tuberculosis. And we see less amyloidosis associated with things like rheumatoid arthritis as the biologics have become more widely used. So I do think that aggressive treatment, and that's certainly what we do with the periodic fever syndrome patients, is that we really aggressively treat their underlying inflammation to the point that we want to normalize their acute phase reactants. Now, in terms of who's at risk for amyloidosis, that's also an excellent question. Now, it's probably been looked at most systematically in patients with FMF. And so in FMF, certainly the mutations that are associated with more severe disease, as you might expect, are associated with a higher probability of amyloidosis. Males, for some reason, are associated with a higher risk of amyloidosis. Non-compliance with treatment associated with a higher risk of amyloidosis. There is a polymorphism in the amyloid locus, actually, that is associated with a higher risk of amyloidosis, probably because it prevents the normal degradation of the amyloid protein. And then, the most captivating of all association is that it depends on where you grow up as to what your chances of getting amyloid are, at least with FMF. Armenians who grow up in Armenia, for example, have about a 25% risk of developing amyloidosis by the time they're 30. Armenians in the United States with the same spectrum of mutations, even if not treated with colchicine, have less than a 1% risk of developing amyloidosis. And there was a big study done by Isabelle Touatou, published in Arthritis and Rheumatism a few years ago, that looked at country of origin as being really one of the major predictive factors in whether or not you get amyloid. And people who come from countries where infant mortality is higher, and therefore we think the healthcare availability may be lower, have a higher risk of developing amyloid for reasons unknown, but that seems to be the case.
Could you comment on whether populations that practice cousin marriages, some that homo mother nature would take to extinguish?
Say again?
So populations that use cousin marriages, if they were to move away from it, how long would mother nature take to extinguish those beings?
Well, that's, so we do think, and I didn't have time to talk about this, that at least at one time there may have been a selective advantage for mutations at the FMF locus. And in fact, if you look at the carrier frequency for mutations in this gene in Mediterranean, Middle Eastern populations, it's incredibly high. It's like 1 in 3 to 1 in 5. Now, if you contrast that with the carrier frequency for cystic fibrosis, which is the most common lethal recessive disease in Caucasians in North America, 1 in 20. So this is incredibly high, 1 in 3 to 1 in 5. And there's been a lot of speculation as to whether there might be, or might have been, some infectious agent that was selecting for these mutations over the centuries. So far, at least in various epidemiologic studies and studies of experimental animals, we haven't figured out what that agent would be. Apparently not, no.
that you mentioned?
Yes. So both excellent questions. With regards to the amyloid of Alzheimer's disease, it's a different protein that is being deposited, A beta, as opposed to AA. So it is a different chemical process, although it does appear there are some studies that would suggest that IL-1 does play some role in the pathogenesis of even the amyloidosis in Alzheimer's disease. So that's an area still under study as to whether or not maybe that would help in some way. But the thing is, all amyloid looks the same under the microscope when you stain it with Congo red. It all gets this, if you look at it under polarizing light, this apple green birefringent appearance to it. But it's, you know, different proteins that are being deposited, but probably there's some final common pathway that makes them, you know, misfold and deposit in that way. So that's an interesting question. Now the question as to whether or not colchicine would have a role in treating some of the other amyloidoses, that's something that one could consider. There was the thinking back in the old days that colchicine might be effective in FMF even if you can't prevent the attacks, that it might still prevent the amyloidosis. Colchicine does prevent the amyloidosis of FMF, but it appears that that's related to its ability to prevent the inflammatory attacks of FMF. So it's not that it has an anti-amyloidogenic effect, it has an anti-inflammatory effect in that disease, which then leads to less burden of SAA in the blood and less to deposit. So we don't think that it's because it has a direct effect on amyloid deposition. As far as the cost of colchicine, just a word about that. As some of you may know, colchicine used to be available as several generic forms in the United States, and then because of some well-intentioned legislation, it turned out that if a maker of a drug like that, which had never undergone appropriate clinical trials, if a maker of the drug went through certain tests with the FDA, they could then get exclusive license and put all of the other companies out of business. So there's a company, Union Pharmaceuticals, that did just that using gout as the prototype. And so essentially at this point, there's only one form of colchicine that is available in the United States. The trade name of it is Colchris, and it's made by this company, Union Pharmaceuticals. And the cost of colchicine has now gone up from roughly 10 cents a tablet to $5 a tablet, which will persist for the length of time that they have an exclusive license on this. And again, this was something that was well-intentioned, you know, in the idea that this would encourage further rigor in terms of the testing of agents that had never been subjected to the scrutiny of modern trials. But, you know, it's ended up sort of causing this issue with regard to the cost of the drug. And actually, Colchris itself, we've seen in some of our patients, is perhaps milligram per milligram or 0.1 milligram per 0.1 milligram, a little bit less effective than some of the other generic forms. And so, in fact, one has to make dose adjustments in the patients when they switch from their generic to Colchris. So an interesting thing, sort of a quasi-political, medical political kind of issue, I guess.
Is there a dark side to toning down the inflammasome in terms of risk of infection?
It's a great question, Gene. So we don't see a lot of problems. Certainly the TNF inhibitors are a lot more associated with opportunistic infections, with mycobacterial infections, with fungal infections than IL-1 inhibitors. We do see some increase in risk of upper respiratory illnesses, but at least at the doses that we give for these diseases, no, we do not see. Part of the problem is, the thing with these patients is that they have a very hyperactive innate immune system, and so what we're doing, treating them with the IL-1 inhibitors, is sort of bringing it back to normal. In a lot of cases, parents of kids with these diseases will say that everybody else in the family will get a cold or the flu, and this child who's not been treated yet doesn't. They may get their recurrent fever syndrome, but they don't get colds and flus. when we treat them with IL-1 inhibitors or whatever other biologic, then they no longer have their periodic fever episodes, but they, like the rest of us mortals, begin to get colds and flus like anyone else.
It's going to be a very hard act to follow. Thank you very much for coming.
Thanks, Jim.